Pathophysiology assessment and management of specific cardiovascular problems. Epidemiology of cardiovascular disease. So, according to the American Heart Association, cardiovascular disease, CVD, is the leading global cause of death. It is estimated that more than 1 in 3 Americans has one or more type of cardiovascular disease. You have coronary heart disease, CHD. So we have a disease of the coronary arteries that are associated with signs and symptoms and complications such as angina pectoris, pain of pectoris, and acute myocardial infarction. Patient with coronary heart disease have 5 to 7 times the risk of having a heart attack or dying, characterized by atherosclerotic narrowing and eventual blockage of the arteries that supply the heart muscle with blood. Acute coronary syndrome. It's characterized by diminished flow through the coronary veins, coronary artery occlusion by a blood clot, also known as a thrombus. Coronary artery spasm, reduction of the overall blood flow from any cause if the blood vessels become blocked, tissues that are deprived of oxygen and nutrients. This is going to cause ischemia. When the ischemic process is not interrupted, you're going to get tissue death. This is infarction. Etiology. The usual cause of acute coronary syndrome is the rupture of the sclerotic plaque. Atherosclerosis is going to affect the lining of the blood vessels. It's going to lead to narrowing and blood flow reduction through the vessels. The atherosclerotic process is as follows. Small amounts of fatty material that are deposited along the arteries and the inner wall. Fat gradually enlarges and becomes a mass of fatty tissue. This is atheroma. The atheroma eventually calcifies, hardens into a lesion. The lesion infiltrates the arterial wall and diminishes its elasticity while decreasing the amount of blood flow through the lumen. This area is ideal for site formation of a thrombus, which can then obstruct the artery altogether. Calcium may precipitate into the arterial wall, causing arteriosclerosis, reducing arterial elasticity. Risk factors. If you're more than 90% of what is this word? Not acute, coronary heart disease, CHD. Types of risk. So more than 90% of coronary heart disease is events occur in people who have at least one risk factor. Non-modifiable risk factors, and then there's modifiable risk factors. So risk for CHD include hypertension, cigarette smoking, high serum cholesterol levels, lack of exercise, obesity, family history, male gender. Oh, that sucks. People address the following factors and make them modifiable risk factors. Diabetes, patients that lower the risk of CHD, cerebrovascular disease, peripheral vascular disease, and heart disease, improving their overall health. Excessive alcohol consumption. People can lower their blood pressure and triglyceride levels, which can be raised by excessive alcohol consumption. A diet in saturated fat, trans fat, cholesterol, so people can lower their risk for atherosclerosis and heart disease by lowering cholesterol, by lowering intake of these saturated fats and trans fats, which would also reduce the risk of heart attack, cholesterol, and it can also be controlled with medication if necessary. Obesity. Patients with obesity have increased likelihood of other CHD risk factors, such as high blood pressure, diabetes, high cholesterol, a sensible diet with increased physical activity that can lower the risk of CHD. Lack of exercise. Exercise improves overall fitness, cardiac reserves, and collateral coronary circulation. Stress levels. People who learn to manage their stress better and more effectively can lower the risk of CHD and associated risks. Contributing factors. Definitely sleep. Did we already talk about that? Education, family income, employment. Angina pectoris. Principal symptom of CAD, pain that occurs when the oxygen supply to the myocardium is not enough to meet the demand. A switch to the anaerobic metabolism leads to a buildup of carbon dioxide and lactic acid. During exercise and other physiological stress, Patient may not have enough blood flowing through the myocardium to satisfy increased demand for oxygen. If the angina occurs at rest, then the patient has a more severe form of CAD. It's important to distinguish between stable and unstable angina. Stable angina follows the recurrent pattern. Pain occurs after a predictable amount of exertion, which is predictable in location, intensity, and duration. Patients often take some form of NTG, not NSAIDs. What is NTG? ST segment depression or inverted T waves are going to show up on the ECG or EKG. The EKG changes and resolves whenever the heart's oxygen demand is met. Unstable angina, more serious, indicates higher levels of coronary artery obstruction, characterized by changes in frequency, severity, and duration of pain and other symptoms. More frequent and severe attacks, which may begin during sleep or at rest. Warning signs of an impending myocardial infarction. Prince Meadows angina fluctuates, or vasospastic angina, caused by coronary artery vasospasms and result in chest pain at rest. It's caused by emotional stress, hyperventilation, exercise, and cold weather. Can occur in patients with normal coronary arteries as well as patients with CAD. Resolutions of symptoms on their own with or without NTGs. Increased risk of dysrhythmia, acute myocardial infarction, syncope, and sudden death. Acute myocardial infarction, pathophysiology. Part of the cardiac muscle is derived of the coronary blood flow long enough that portions of the muscle die. The location and size of the infarct depends on which artery is blocked and where. Most infarcts involve left ventricles, and when the anterior lateral or septal wall of the left ventricle are infarcted, usually from the occlusion of the left coronary artery or one of its two branches. RCA, right coronary artery occlusion, is usually because of inferior wall infarcts. Subendocardial myocardial infarction is when the ischemic process affects the inner layer of the muscle only. Transmural myocardial infarction is whenever the infarct extends through the entire wall of the ventricle. Infarcted tissue surrounded by a ring of ischemic tissue that is relatively deprived of oxygen but still viable. The tissue is electrically unstable and may be the source of cardiac dysrhythmias. Patients with a STEMI have an EKG evidence of a ST segment elevation. NSTEMI produces no signs of myocardial injury on the patient's EKG. Distinguishing patients with unstable angina from those with acute myocardial infarction may be impossible during presentation. Signs, symptoms, and EKG findings are associated with these two conditions may be identical. Assessment. So with goals, we identify the STEMI and whether it's present, and if so, notify the medical facility. Determine the time of symptoms and onset. Monitor cardiac rhythm and vital signs. Be prepared to provide CPR defibrillation if needed. Administer appropriate medications and transport to the appropriate facility. Oh, I think we already passed this. Did we do this? Where are we at? 250. Yeah, we went through these. Or did we? We went through these.